Hi again, this is Jim Rush, and once again I'm putting a number of YouTube presentations up on the web with the hope that the people who are both current and future emergency managers, especially in the healthcare and public health emergency management career fields, can derive some benefit from them. That's the goal. Anyway, today I'll be talking about the what I call the 4-echelon disaster casualty management system. This pertains to mass casualty management. I know many hospitals are working on their mass casualty management preparedness right now. There's a number of world situations that are going to test the level of our healthcare's ability to expand and handle surges in medical casualties. Historically, many of our advancements in terms of trauma and patient care have come from the military, from the armed forces, in areas like especially orthopedic surgery, burn management, trauma management, and reconstructive surgery. There was also advances since World War II in the rapid transport of patients. The Korean War demonstrated that the air ambulance, the helicopter as a air ambulance, significantly improved the survival rates of our battlefield casualties. And the air ambulance concept was picked up by the civilian sector in the early 70s and is now a major part of our trauma management systems around the country. Now, during the Cold War in Europe, we were preparing for the possibility of World War III, a very grim prospect, and we all knew that. But we needed to prepare for it anyway, and the idea was that if the Soviet Union's attacked, they would come in into the central region of Germany and would provide quite a foe. In 1980, the General Accountability Office found in a study that the air forces in Europe were not capable of managing the numbers of, or the categories of casualties that would result from a war that started in the central region of Germany. Congress gave the United States Air Forces Europe a directive to develop a system that would be able to better manage the casualty numbers that we were anticipating. A team from USAFE, that's the United States Air Forces Europe, traveled to Israel, and we received briefings from the medical corps of the Israeli Defense Forces. And what they came back with was the recommendation to adopt the Israeli 4-echelon casualty management system that had proven itself during the Yom Kippur War for Israel. The emphasis was on rapid movement, early stabilization. The golden hour, we all know that now, but the golden hour stabilization they found was key to improve survival rates. And then once you stabilized as many people as had a chance of surviving onward, they were moved to more rearward to casualty, to medical centers that could provide full suite of services for the battlefield casualties. And also the fourth stage, or the 4th echelon, was rehabilitation, and that means basically anything from long-term ventilator support to amputations and prosthetics, building and manufacturing, etc. And the United States Air Forces adopted that as our medical doctrine in the 1980s. It can be, you say, no, okay, that's fine for military applications, but how about for the civilian sector? We're ready for it in many aspects. When I was with the National Bioterrorism Hospital Preparedness Program, it's now the Hospital Preparedness Program, we were talking about using coalitions of hospitals and tiers of integration. So starting from the immediate disaster area and moving out to the areas surrounding the disaster area, and then outward from there. And the further out you go, the further the full services were rendered. But in the immediate area, it was going to be stabilizing during the golden hour. And it also used ground and EMS airlift for the casualties. So basically, what is it? First echelon's very austere, very basic. Control the bleeding, administer antidote if it's a chemical environment, establish an airway if you can, and rapid transport to the second echelon. And once you get to the second echelon, what is it? It's an emergency room or a trauma center. And its goal in that jurisdiction where the disaster happens, under this concept, every hospital, every emergency room, every trauma center would be second echelon. And all they'd be doing is stabilizing and transport. Stabilize and transport. Those who weren't able to be stabilized, of course, would be given palliative care right there. And there would be a mortuary established at the second echelon. What types of services? We're looking at advanced cardiac life support, advanced pediatric life support, blood, IV solutions, IV fluids. Blood donor center should be near the second echelon because there's going to be a need for a lot of blood. And this second echelon, as it's exercised, it's an excellent opportunity for your jurisdiction to set up a blood drive every single time you exercise the second echelon. Basically, transport ventilators would be provided. Typically, no radiology or lab services. And again, this is very austere, and it's meant to stabilize as many people as you possibly can during their golden hour and move them out to the third echelon. Now that's where you get into a full suite of diagnostics. Basically, a medical center is what bricks and mortar is what we're looking at in third echelon. Surgeries and specialties, major medical center or hospital, patients released to home, or if they need to have ongoing rehabilitation, they go on to the fourth echelon. There's no prosthetics or long-term rehabilitation typically at the third echelon. And then when you get in the fourth echelon, you get into reconstructive surgery, ventilator support long-term, prosthetic devices, full spectrum of rehab services, patients released to home, or the patients released to long-term health facility. So that's basically a quick overview of the four echelon. Its qualities or its capabilities. It's a rapid throughput outward after stabilizing as many people as you possibly can. It minimizes a backlog, and that's what we have right now, I believe. If we had a very large disaster in a metropolitan area, the current system would be transport those that are immediate or high chance of survival if you can get to them to the local ERs and the local trauma centers. After that, it gets trickier. Now you have to go further and further out under the current system. And consequently, as you're going further out, those immediates could become expectants. And in the meantime, you're backlogging at your disaster jurisdiction. So it's a real challenge right now to try to stabilize everybody. And I don't see how you can stabilize everyone within their golden hour unless you adopt this four echelon system. They've proven, and the armed forces are using the four echelon concept right now, and it has proven that it saves lives, and it is, I think, the future of American catastrophic care. Thanks a lot for tuning in, and I'll be back with another presentation real soon. Again, thanks.